Good day. I am Dr. Roland Joseph Tan, and I'll be discussing binocular single vision. Some parts are a bit technical, so please bear with me. This will be the outline of my lecture. We'll start with the definition, and then I'll be discussing two significant components of binocular single vision, which are motor fusion and sensory fusion. And then we'll be discussing its development, the theories involved, its uses, some of its pathologies, and of course, clinical assessments. By definition, binocular single vision requires three components. These are motor fusion, which is a result of precise motor coordination, sensory fusion, which is also a result of precise motor coordination, and of course, up to your visual axis. So fusion is defined as a process that is made centrally, particularly in the visual cortex. So to achieve motor fusion, both eyes should move together. Motor fusion is necessary to ensure sensory fusion. There are different neurological pathways that you have to familiarize yourselves, particularly those of conjugate cases. So coordination for conjugate cases, particularly in this example, where both eyes are looking at the right side or right gaze, the stimulus starts from the left area 8, then to the right PPRF or the paramedian pontine reticular formation, and then to the right cranial nerve 6 nucleus. This goes all the way up to the cranial nerve 6 cranial nerves 6, and then there's another connection that goes to the contralateral medial longitudinal fasciculus, or the MLF, which goes into the cranial nerve 3 nucleus, or the oculomotor nucleus, which then eventually goes all the way as cranial nerve 3. So the cranial nerve 6 innervates your right lateral rectus, while your cranial nerve 3 nucleus, your cranial nerve 3 innervates your left medial rectus. So for convergence, the oculomotor nucleus is activated together with the accommodation reflex. Now, once activated, both MRs contract, so there's convergence. To achieve sensory fusion, two similar images from one object shall fall in corresponding retinal areas in the two eyes. So they must be the same size and clarity. So retinal correspondence, a subject seen by two eyes must form an image in corresponding areas in the retina for it to be interpreted as one. So normal retinal correspondence is defined as both fovea having a common visual direction. So the retinal elements nasal to the fovea, for example, this is the fovea, this is your right eye. So the elements that are located in the nasal area of the right eye should be located or corresponds to the retinal elements temporal to the fovea in the other eye. Okay, so that's normal retinal correspondence. So an important concept in retinal correspondence is the horopter. So the word horopter comes from horos, which means boundary, and opter, which means observer. It's basically the locus of all object points that are imaged on corresponding retinal elements at a given fixation distance. It is introduced in 1613 by Agollonius, and it has three components: the Biet-Muller circle, the empirical curve, and the Pannon's fusional area. So the Biet-Muller circle, which is colored here, the red circle, it's a theoretical and a geometrical circle. It is a circle formed when all corresponding points with regular horizontal distance from the retina are traced. Okay, so as you can see here, points A, B, C, D, E, F, G, and then goes around as well. Okay, So the circle passes through the center of the rotation of the two eyes, this area or the nodal points, and the fixation point, which is here, point D. The circle becomes smaller as the point of fixation gets nearer. The empirical curve is slightly flatter than the Binocular circle. So this is the empirical curve, okay? It has greater radius of curvature, and the deviation between these two um, structures, the empirical horopter and the Binocular circle, this letter G, or sorry, this space, it's called the deviation of the perceptual, or also known as the Herring-Hillebrand deviation. So this deviation is being attributed to both neural and optical factors, where nasal hemiretina of at any given eccentricity contains more photoreceptors per unit area than the temporal hemiretina, producing a deviation in the horopter mapping in the visual cortex. So yes, all the points not lying on the empirical curve are imaged by disparate retinal elements and should be seen as double. However, there is a third component of the horopter, which is called the Panem's fusional area. So it is a narrow band around the horopter within which the objects stimulate disparate retinal elements, but still transmit the impression of a single vision. So it's this area. So this is the empirical curve being discussed a while ago. So anything that falls behind or in front of it should be seen double. However, if it's as long as inside this Panem's fusional area, then it can still be seen as, or it can be still seen as one. So it is the narrowest. It is narrowest at the fixation point in the central area and becomes broader in the periphery at a rate of 1 to 2 arc minutes per degree of visual field eccentricity. So the horizontal extent of this area is small at the center, 6 to 10 arc minutes near the fovea, and increases towards the periphery around 30 to 40 arc minutes at 12 degrees from the fovea. And then the increase in the Panem's area towards the periphery may be related to anatomic and physiologic differences known to exist between the monosynaptic foveal cone system and the rod and cone system of the periphery. So again, all the points not lying on the empirical curve are imaged by disparate retinal elements and should be seen as double. However, these points that fall inside this red rectangle, the Panem's fusional area, although diplopia is elicited, can still be fused. So this is called physiological diplopia. There are two types of physiological diplopia. When the object is between the empirical curve and the eyes, the diplopia is crossed, okay? So as a result of the image falling in the temporal areas of the retina. So as you can see here, so okay, so this is your empirical curve, this is your eyes, so the object is between them, okay? The image produced falls in the temporal area, temporal to the fovea, temporal areas of the eyes. So this produces across the diplopia. When the object though is behind, so if this is your empirical curve, the object is here, diplopia produces uncrossed since the images produced are in the nasal area, okay? So moving on, the development of binocular single vision is achieved at all times by having normal or properly developed anatomical and physiological components, okay? So the two eyes are so situated in the orbit that the visual axis is directed in the same direction, okay? So this is due to the shape of the orbit. It has to be of normal depth and size, and similarly, the eyes in the other periocular structures have to develop accordingly. So there are adjacent ligaments, muscles, and connective tissues involved that suspends the eyeball or suspend the eyeball in the orbit, which make it securely in place while making it very mobile. So physiological components include the reflexes. So its development requires that all anatomical components are normal. So for fixation reflexes, we have the compensatory fixation reflex or the gravitational reflex. So its function is to keep the eyes in a fixed position, and it's due to the frontal direction of the eyes and the utricles and the saccules presiding over the tone of the vertical recti and obliques, respectively. So the second one is the orientation fixation reflex, which can be demonstrated by the eye following and moving object or panorama, thus exhibiting a comparatively slow movement of continued fixation and not a rapid jerk fixation. So this reflex relates to horizontal axis. The accommodation convergent reflex is aimed at correctly aligning the eyes and keeping them focused on the object. So it includes Burton's fixation reflex, accommodation reflex, and fusional Burton's reflex. So, and then of course, lastly, the refixation reflex. So it relates the eye back. Sorry, it relates the eye back to the original orientation point or to the new orientation point. So, at birth, the fixation reflex is poorly developed, and with the child having only random, non-conjugate, and aimless ocular movements. There is inability to carry out pursuit movements during the first few weeks of life. So the development of the optomotor reflex is essentially a postnatal event with the approximate time schedule being around 2 to 3 weeks. Um, so the patient can, or an individual can follow light monocularly, and at 6 weeks to 6 months, patient or individual can already follow binocularly. So convergence, which is absent at birth, it starts developing at 1 month of age and is well established by around 6 months. So accommodation lags behind the development of convergence due to the delay in the development of ciliary muscles. It parallels with the convergence by around 6 months of age. So electrophysiological studies have shown that infants can detect retinal disparities between 2 to 5 months of age, but little is known about the development of stereo acuity between the ages of 6 months to 3 years, when the child may sufficiently be able to comprehend subjective tests. However, it is generally agreed that there is a gradual improvement in stereo acuity up to the age of 9 years. It is said that in human beings, the sensitive period of development of binocular vision begins at about 4 months of age, peaks at 2 years, and is well developed by 4 years old. And it slowly declines to cease by around 9 years of age. Now, these estimates assume that a single sensitive period during which the binocular function appears to be at a risk is during the first 2 years of life. So, any obstacle in the reflex pathway is likely to hamper the development of binocular vision. So, there are many theories on how binocular single vision is achieved. However, only two will be discussed here. The first one, the widely accepted one, is that of correspondence and disparity. So it assumes the presence of one-to-one retinocortical relationship between the two eyes. When stimulated simultaneously by one object point, they transmit a single visual impression with no depth quality. When stimulated simultaneously by two object points that differ in character, binocular rivalry occurs. When disparate elements are stimulated by one object point, diplopia occurs. However, if horizontal disparity remains within the Panem's area or the Panem's fusional area, which I mentioned earlier, a single visual impression is elicited with depth or stereopsis. So the perceived depth increases with increasing disparity. However, with increasing disparity, the quality of stereopsis decreases, which may eventually lead to diplopia. So the second theory is that the neurophysiological the neurophysiologic theory. So it is based on animal experiments of Hubel and Wiesel, which showed that roughly 80% of the neurons in the striatal cortex can be driven from either eye in response to a visual stimulus from the retina. So, assuming that there exists a precise and orderly arrangement of connections along the entire retinogeniculate striate pathway. So, 25% of these binocular driven cells were stimulated equally from each eye, while the remaining 75% represented graded response from either left or the right eye. Now, cells that could be driven by stimulation of either eye had receptive fields of nearly equal size and in corresponding positions of visual field. So this theory supports that the decussation of the optic nerves at the chiasm is essential for the development of binocular vision. With it, visual information from corresponding retinal points, these areas, of each eye runs via adjacent parallel separate circuit through the LGN, okay, and the optic tracts to the visual cortex. So the LGN is the principal thalamic visual nucleus linking the retina and the striae complex. It contains actually three cellular systems, which includes the magnocellular, the parvocellular, and the coniocellular. These are the main neural system in the pathway. So magnocellular system are made of cells that have large somas and axons. They are rarely connected with ganglion cells in the foveal area and are sensitive to moving stimuli. So they are also insensitive to color and only receive 10% of the retina input. The parvocellular system, on the other hand, are made of cells with small soma and axons. So they connect to a lot of ganglion cells from the fovea and carry high resolution information about an object's borders, color contrast, and shape. So they receive about 90% of all retinal input. Little is known about the third system, which is the coniocellular system. However, they found that it is significant in color perception, especially blue. So the LGN on the left side has six lamina. Lamina 1, 4, and 6 receive axon from the nasal retina of the right eye, while lamina 2, 3, and 5 receive axons from the temporal retina of the left eye. Now, these systems from the LGN all go through in V1, this area of the striate cortex. Some terminates in B1, others continue to the other parts of the striate complex. Okay. Each part of the striate cortex has particular use in vision, such as orientation, direction, and ocular dominance. So, what's the advantage of having binocular single vision? Well, one is you have a spare eye if something happens to your dominant eye or to one the other eye. Okay. Another would be having a maximum horizontal field of view of approximately 190 degrees with two eyes being used. Now, approximately 120 degrees of which makes up the binocular field of view. Okay, which means this is being seen by both eyes, flanked by two uniocular fields seen by only one eye of approximately around 40 degrees. Now, this can also allow you to see objects behind obstacle. And lastly, of course, stereopsis. So what is stereopsis? So stereopsis is the ability of both eyes to fuse images that lie within the panum's fusional area, resulting in three-dimensional perception of the object. So diplopia elicited by an object point of the horopter, but within the panum's fusional area, is known as physiological diplopia, as mentioned or as discussed earlier. So let's discuss pathologies. So, of course, an important set of pathologies includes those that affects the motor fusion. So this includes extraocular muscle pathologies such as congenital fibrosis of your extraocular muscles, Duane syndrome and Brown syndrome, cranial nerve palsies, particularly those that involve the cranial nerve 3, 4, and 6, and congenital craniofacial malformation, including croissants, which results to shallow orbits. Okay. For sensory obstacles, you have dioptric obstacles such as media opacities and uncorrected errors of refraction. It can also be prolonged uniocular activity. For example, patient suffers from severe ptosis or anisometropia, or there's a significant difference between the refraction of uh, between the two eyes. Okay, so can also be retino-neural obstacles such as lesions in the retina or the optic nerve, and of course proprioceptive obstacles. So the presence of these obstacles that was mentioned earlier can give rise to various sensory adaptations to binocular dysfunction, especially if the disruptive factor is present in the sensitive period of around the 4 months to 2 years old. Okay, this can be in the form of an anomalous retinal correspondence or ARC, suppression, or amblyopia. So I'll only be discussing ARC and suppression since I think amblyopia will be discussed either later on or somewhere else. Okay. So binocular single vision can be classified as normal when it is bifoveal, meaning both foveas are working well together, and there is no manifest deviation. Okay, so binocular single vision is anomalous when the images of the fixated object are projected from the fovea of one eye and an extrafoveal area on the other eye. Okay, so this is common in small angle strabismus uh, to have an extrafoveal point near the fovea. Okay, so um, ARC develops as an attempt to regain binocular advantage, although, as mentioned, it's anomalous, and it can result in the eye seeing binocularly single in spite of a manifest squint or misalignment. So, under monocular conditions, central fixation is retained by the fovea, uh, which is basically the basis for the cover test. Of course, the stereopsis, it varies depending on the amount of squint. Okay, so let's take this for example, these three pictures. So for A, in normal retinal correspondence, images which fall at roughly the same position, so triangle, triangle, sun, sun, heart, heart, okay, relative to the fovea are perceived lying in the same visual direction. These correspondence are marked by the dashed vertical lines. Okay, so however, in letter B, there's an exodeviation or exotropia. Uh, these correspondence are inappropriate. So corresponding retinal locations are stimulated by different objects, resulting in confusion and or diplopia. So in anomalous retinal correspondence in letter C, the corresponding points are remapped to account for the deviation. Okay, so now images falling at very different retinal locations, much further apart than the normal range of usable disparities, are perceived as lying in the same direction. So another sensory adaptation mechanism is suppression. So it's a neurophysiological active inhibitory mechanism in which when corresponding retinal areas are stimulated by dissimilar stimuli, or when non-corresponding retinal areas are stimulated by similar stimuli, one or the other is temporarily inhibited or suppressed to prevent confusion or diplopia, respectively. So suppression is foveal in order to tackle confusion, while it can be extrafoveal in order to avoid diplopia. There are different forms of suppression. It can be central or it can be hemiretinal. It can also be facultative or obligatory. So facultative suppression is only under binocular conditions with no persisting hangover under monocular conditions. Okay? So the visual acuity is not reduced under monocular conditions, and there are no uniocular scotomas in the visual field. For obligatory, on the other hand, it is the effect which carries on even under monocular conditions. This results to the diminution of the visual acuity, and amblyopia is the fallout of this obligatory suppression. So, to moving on to the abnormalities of binocular vision, we have diplopia, which is retinal disparity, and visual confusion, which is retinal rivalry. So this picture, it's more of disparity. So I think this is diplopia. Okay. So in diplopia, so simultaneous stimulation of non-corresponding and disparate retinal elements by an object point causes this point to be localized in two different subjective visual directions. Okay, so an object point seen simultaneously in two directions appear double. When dissimilar contours are presented to corresponding retinal areas, fusion becomes impossible, and retinal rivalry may be observed. So this is, on the other hand, this is, if the other one's diplopia, this is visual confusion, okay? So in order to remove this confusion, image from one of the eyes is suppressed. This constant foveal suppression of one eye with cessation of rivalry leads to complete sensory dominance of the other eye. So this is a major obstacle to binocular vision. So return of retinal rivalry is a requisite for reestablishment of binocular vision. So as you can see here in this picture, the patient sees two objects at the same space. Okay, so now there are different tests to assess suppression, ARC, and other pathologies of binocular single vision. However, I'll be only discussing this since it would be it would take a lot of time to discuss all of the tests. Okay, so I will be explaining how these tests are done and what the expected results will be and what do these results mean. Okay, so let's start with the red glass test. So the red glass test, it detects diplopia and suppression. Okay, so prior to doing the test, the deviation should have been measured objectively already using prisms. Okay, now the red glass is placed, for convention, the red glass is placed in the non-deviating eye. In this in the example, in the front of the left eye, the next slide. Okay, so suppression is present if patient can only see a red or a white light. Okay. For diplopia or for diplopia, patient sees two lights. Okay. So for letter D, there's two perceived lights. Okay, indicating a diplopia. Since the white light is on the right side here, the side without the red glass, then the diplopia is uncrossed, as opposed to letter E, where the white light is on the left field, which makes it a crossed diplopia. So the Bagolini straighted glass test can be used to test retinal correspondence and suppression. Now the Bagolini lens are oriented at 135 degrees in the right eye and at 45 degrees in front of the left eye. Okay. A is the result of the test for patient who is orthophoric and with normal retinal correspondence. B is the result of the test for patient with small deviation less than 8 PD with peripheral fusion. However, there's presence of central suppression, thus this space. Okay, often this condition is called monofixation syndrome. C is the result of the test for patients with exotropia with normal retinal correspondence with no suppression and is experienced cross diplopia. D is the result of the test for patient with esotropia with normal retinal correspondence with no suppression and is experiencing uncrossed diplopia. E is the result of the test for patients with right hypotropia with normal retinal correspondence, with no suppression, and is experiencing vertical diplopia. F is the result of the test for patients with large deviation, horizontal deviation, with normal retinal correspondences, with no suppression and experiencing horizontal diplopia. G is the result of the test for patients with right eye suppression, while H has a left eye suppression. Okay. So in this test, a pair of glasses is worn for the word for that. Okay, with the red glass over the right eye, and the left eye and the green glass over the left eye. So the right eye will not be able to see a green light since the red glass blocks the green wavelength, and vice versa. A target is then shown, which consists of two green lights, here and here, one red light, and one white light. Okay. In letter B, patient A, who is orthophoric, will report seeing all four lights, with the white light reported to be either red, green, or even pink. If the right eye, if the eye behind the green glass is suppressed, then patient can see letter C. Okay, so can see only red, red letter, or sorry, red dots, the two red dots. Okay, if the eye behind the red glass is suppressed, a total of 3 lights is reported, letter D. If the patient reports 5 lights, diplopia is present. And for letter F, there's a monofixation syndrome wherein there's central suppression with peripheral fusion. For F1, this is done testing was done at 6 meters, which reveals suppression of the left eye. But in F2, testing was done at 33 centimeters, which reveals normal testing because testing subtends an angle outside of suppression scotoma. So became normal, okay? So amblyoscope testing can determine whether a patient has NRC or ARC. The amblyoscope has two arms, which can be used to measure both the objective angle by the examiner and the subjective angle by the patient. So the objective angle is the angle by which the target's image on the two foveas produce no movement with alternate target presentation. If the images are seen superimposed with the angle between the arms of the amblyoscope equal to the objective angle, then correspondence is normal. If not, correspondence is anomalous. The patient is then asked to superimpose the two targets. If superimposition occurs with the amblyoscope arm set at 0, the patient shows harmonious ARC. However, if the arms set somewhere between 0 and the objective angle, then unharmonious ARC is theoretically present. So this is the summary of the 4 tests I discussed. So the red glass test used to detect suppression in ARC. The convention uses the red glass over the fixating eye. For the Bagolini, also for suppression in ARC, the right eye streak is at 135 degrees, while the left eye streak is 45 degrees. Word for dot for suppression, the red glass is usually put in front of the right eye, and of course the amblyoscope for your anomalous retinal correspondence. Okay, so thank you very much.